It is my pleasure to introduce another panel, and this is session 3, Intersectionality between Infectious Disease and Drug Use. And so we have three panelists for this session. Um, so I'll start off with Dr. Irene Kuo. Irene Kuo is an associate research professor in the Department of Epidemiology at the George Washington University Milken Institute School of Public Health. Her public health research has focused on the intersection of infectious diseases such as HIV and hepatitis C virus and opioid use disorders. Currently, she is leading an HIV prevention trials network study to examine the effectiveness of the provision of integrated services for medication for opioid use disorders and HIV and hepatitis C care and prevention in a mobile unit setting to people who inject drugs in Washington, D.C. Our other panelist, Kevon Smith, is from Oxford, is the Regional Housing Chair for Oxford House. Kevon Smith is a Washington, D.C. native, born and raised right here in Northeast D.C. He's the current Regional Housing Service Chair of Oxford House, Inc., where he passionately counsels men and women of all ages new to the path of recovery. Following a 7-year stint in active addiction, Kevon brings lived experience to the panel and a conscious understanding of the internal recovery process. And then our third panelist, who we have a new panelist, and I just want to give themselves a chance to introduce. Do you have a mic? Is there a microphone?
Hi, my name is Yona Tangi. I'm a healthcare provider at Women Walker Health, where we do comprehensive primary care. I do all sorts of care, but I do focus on substance use care, specifically opioid use disorder. We're starting a Sublocade program, as well as I specifically specialize in stimulant use disorders and chemsex use disorders in queer communities. And I will leave it at that.
Awesome. No, thank you. Thank you, and thanks to our panel for assembling today. So we're going to start off with Dr. Kuo's presentation on the intersection of HIV and substance use and the need for integrated care. So Dr. Kuo, it's all yours.
Thank you, Corey. Oh, how do I
You have the
advance?
clicker. Here's the clicker.
Oh, okay. Oh, great. All right. Can everyone hear me? Oh, great. Hi. It's nice to see everyone. Thanks for attending the session right after the break. I know it's a little bit hard because I'm sure everyone wants to stretch their legs. Anyway, I just wanted to thank you, Corey, for inviting me to talk about the intersection or the overlap of HIV risk and substance use. And then I'm going to sort of tell the story about, how people who use or inject drugs are at increased risk for HIV. And then the things that we need to do, which all sort of lead us to, at least lead me to the realization that we need to provide integrated care services for people who are affected by substance use disorders. All right, so I know there's a wide variety of people in the audience, ranging from community members to community stakeholders to professional people who work in the clinical field for HIV and substance use. But I think the one thing that we all know is that drug and alcohol use increases the risk of HIV transmission, and then also impacts the downstream effects, like if once someone becomes HIV infected, interrupts the continuum of care for these people. So as I'm sure most all of us are probably aware, there are specific behaviors that lend itself to, that facilitate HIV transmission, including sharing injection equipment that has been used by someone else or has been contaminated by HIV, or engaging in unprotected sex. And when I say unprotected sex, I mean condomless sex, as well as sex without a condom where people are not on pre-exposure prophylaxis, which I'll talk more about later. And so drug use and alcohol use, and in this talk I'm going to focus specifically on opioid use, injection opioid use, but all of these things increase sexual risk and injection-related risk. And then downstream reduces the, someone's ability to adhere to HIV medications, which then leads to increased viral load, which then leads to increased risk of transmission, of onward transmission to other people in sexual or social networks in the community. And then, of course, leading to the progression of HIV, of AIDS, development of AIDS. So I put this slide in here because I think, and I'll talk about Washington, data from Washington, D.C., where I think, HIV incidence has actually, we've had a lot of public health victories with HIV in the PWID population. But I put this in here just because I'm sure most of you are aware that there are these emerging HIV epidemics occurring across the country in areas, where there are new epidemics of opioid use as well. And so these are overlapping epidemics, HIV outbreaks that are resulting from new opioid use, transition to injection epidemics. And I just, since this is the harm reduction conference, I want to point out that many of these epidemics, like say, for example, Indiana is probably the most well-known one that happened in 2015 or 2014, as well as in Kentucky and West Virginia. Those are areas where there is very poor access to harm reduction programming. So you can see how this, builds up a perfect storm of injection drug use risk leading to HIV, increased HIV incidence and HIV outbreaks. And the reason why I am bringing this up is because, I think for a while we thought, we've solved the epidemics, syringe service programs work, and they do work. And so I think, we all, I don't think anyone in this room really thought that, but I think funders and public health officials maybe thought like, we're going to put our attention elsewhere. But I don't think we can take our eyes off the prize because these outbreaks are continuing to happen across the country when you do stop funding harm reduction programs. And so this is just a figure that shows the number of HIV cases associated with injection drug use or among people who inject drugs. And you can see from 2010 to about 2015, you see this, nice decline in the number of new infections diagnosed among people who inject drugs. And then after that, you see the stalling of that decline, mainly because of those outbreaks that happened in that previous map. So it's really important to not take, not lose sight of the fact that we have had these public health victories, but you can't take your foot off the pedal once you get there. So these are data from the CDC, from National HIV Behavioral Surveillance, which is a nationwide behavioral surveillance system. DC is one of the cities that collects data for CDC. It happens in 23 cities across the US, and it's basically sampling people who inject drugs in the community just to get a snapshot, get an idea of what the HIV prevalence is and what the prevalence of risk behaviors that are ongoing in this population. So as you can see here in the national data, 6% of the people who were sampled for the PWID cycle, so 6% of the PWID in the study were HIV positive, and overall 32%, so nearly 1/3, still report using a syringe after someone else has used it. So, these risks are still ongoing on a national level, and again, so we can't ignore that fact. So this is the context for DC, and the DC numbers look, really promising. These are numbers from DC Health, which we are partnered with when we do NHBS. But these are based on surveillance data, so data that are reported to the DC Health, the HIV/AIDS, STD, hepatitis, and tuberculosis administration. And So any positive cases that are identified in the community are reported to DC Health. So in DC, we have, it's estimated that there are 1,100 people who inject drugs who are living with HIV. And in 2020, there was only one reported case of newly diagnosed HIV among someone who injected drugs, which seems like an incredible public health victory. Now, just to note, this doesn't include people who also had other HIV risk, may fall in another HIV risk category, including men who have sex with men. So this is purely just among people who just reported injecting drugs. And and then the previous year was only 2 cases. So, I mean, it's a really wonderful, trajectory, and it seemed like a stable pattern. The caveat, and I see Nestor in the audience, and he is nodding his head, and I hope you agree with me, but I think we all know that COVID really took a toll in testing and the ability for testing to happen in the community. So I think, the 2019 number looks really great. I think the 2020 number also looks great, but we need to take it with a grain of salt, just because, with the understanding that testing was not as widespread as it normally is, and therefore it could just represent under testing and under diagnosis. So I think, in the next couple of years, we may see a rebound. And, I think if that is the case, then that is going to lend itself more to arguing for, stepped up HIV prevention among PWID. So again, we cannot take our eyes off the prize. So this is a figure that you probably all have seen. It's the goals for the Ending the Epidemic campaign. And the goal is to reduce new HIV infections by 90% within 10 years. And part of that, let me just put these all out. So, there are several pillars as part of this. The first is testing to identify cases. And then the second is to treat anyone who has been diagnosed with HIV, to get them into treatment and keep them into treatment and get them virally suppressed. And then one of the other pillars is for those who are HIV negative, to get them engaged in prevention activities. So prevention interventions such as taking pre-exposure prophylaxis or getting engaged in syringe service programs. So I'm going to talk about treatment as prevention, just because it's one of the major pillars of ending the epidemic. And it is something that is going to be, meaningful within this population. So treatment as prevention basically means getting people who are living with HIV, getting them started on HIV medication, getting them into care, and getting them sustained on care, and adhering to medication, to reach a point where they have an undetectable viral load, and then they get to a point where they effectively have little or no ability to transmit HIV to any of their other sexual or injecting partners. So the treatment as prevention is an important aspect of ending the epidemic, and the reason why it matters in terms of the PWID population. It looks like it actually matters for all populations, because we know that engagement in care is not 100% in any of our key populations or people in any of these risk categories. But you can see here in the center, the bars here show, this is an HIV care cascade, and the bars show, the blue bar shows the percent of the population that is virally suppressed. And you can see that for male people who inject drugs, men who inject drugs, and women who inject drugs, that rate of viral suppression is at about 50%. So we've got, and this is national level data. So, at best we have, a little more than 50% who are virally suppressed. But that just means that we have a lot of work to do to get those who are not virally suppressed into care and consistently engaged in care so that we can curb the onward transmission. And these are data from DC. So, and HOSTA is really good about putting out data in all these different shapes and forms. And so they developed a care continuum for the PWID population. And it shows that based on their records, based on whoever has been tested and diagnosed and is recorded within the Department of Health, they're able to determine that almost 64% of PWID living with AIDS, with HIV, are virally suppressed. So that is, that's a good sign compared to the national level data, but it does still mean that we have like 33%, like a third of this population that still does need to get engaged in care properly. So that's why you know, treatment as prevention matters in terms of how we deal with, or how, if in allowing us to achieve our ending the epidemic goals. Now, the next thing I'm going to talk about is pre-exposure prophylaxis. So this is something that I think there is a growing interest in getting you know, PWID engaged in pre-exposure prophylaxis. So the recommendations for someone being indicated for PrEP is that it's for anyone who's engaging in condomless sexual intercourse or sharing equipment with a person who is HIV positive or has unknown HIV status. And then also for anyone who has had a recent STI, which indicates sexual risk. So, but people who inject drugs are included in this indication for PrEP. Now, I think I'm not presenting data, and I wish I had a slide on it, but I think there are, you know, there are, I'm not saying this is happening in DC. I think, like, you know, potentially like conflicting perceptions about whether or not people who inject drugs, you know, need PrEP, can manage being on PrEP, can they adhere to PrEP? And so I don't have a slide on that, but it's definitely an issue that I think comes up a lot, not necessarily in DC, but I'm sure parts of DC. So there are 3 regimens, but there are 2 types of forms of PrEP. So there's the oral daily pill, which comes in the form of, they're both tenofovir, but there are 2 different versions of tenofovir, and the trade names are Truvada and Descovy. And they're approved for people at risk for HIV, who have sexual risk, and then people, so Truvada is indicated for people who have injection use risk. So they may not have sexual risk, but they have risk because they, you know, have reported sharing injection equipment, and therefore, you know, are at risk for HIV that way. Descovy is only approved for men and transgender women, so not cisgender women. And then the other form of PrEP, which is a relatively new form of PrEP, is just recently approved, is a long-acting injectable cabotegravir drug with the trade name is Apretude. And so it's a long-acting injection. You get it every 2 months, which could be, you know, could be a game changer in a lot of populations. I think that it's not quite known what the acceptance or the uptake might be among a drug-using population, but so I think that's sort of an open question. But it's definitely now approved. Oh, actually, I'm sorry. I take that back because it is only approved for people who are at risk for HIV through sex. So it actually would not be indicated for people who inject drugs. And so all of these regimens, you know, if they are taken, you know, as directed, if the adherence is perfect, then they're more than 90% effective in preventing HIV transmission. So we have really effective biomedical HIV prevention interventions, which now need, you know, a scale up of uptake within our populations at risk. And so, and I bring this up because PrEP is available for people who inject drugs. But the knowledge and sort of engagement in PrEP is really low. Now, these are data from 2015 and 2018 National HIV Behavioral Surveillance. These are data that we collected for the Department of Health. And, these data show that, I guess it's not that big of a surprise that knowledge of and, having a conversation with a provider, that would be very low in 2015. But, and I don't remember exactly when Truvada was approved. Do either one of you remember? 2012, right. So it had been, it's been around for 10 years. So in 2018, it had been around for many, many years. And there was one seminal study done in Thailand that demonstrated that Truvada, or oral daily PrEP, is effective in preventing transmission of HIV among people who inject drugs. So that's when CDC added that indication in as a group recommended for PrEP. So you can see in DC, in 2018, only just below 20% had even heard of PrEP. I actually find this to be quite interesting, but 4% actually had a conversation with a provider about PrEP, which I actually thought was not bad, but I mean, it's clearly very low, and we definitely need to get that up higher. And then one person reported being on PrEP in 2018. So it is dismally low. But when you couple that, so my fear is that if you couple that with the low number of cases of HIV in the PWID population, then you might say well, does this group really need PrEP because they're are they really at risk? And I just don't think we know that yet. I don't think we know that yet until we get through COVID and have some more data just to really see what's going on in terms of infections that just haven't been picked up yet. So, but what's clear is that awareness of PrEP is very low still within the PWID population, and we are actually currently running our next cycle of NHBS in the PWID population. So we should have data at the end of this year. And then can add another bar to this just to compare across the years to see what people know and what what they're being offered. So this is actually from the DC Health HIV/AIDS annual report, and the report summarized some of the data that we collected from NHBS in the 2018 cycle. And what I wanted to point out is at the end, at the last bar, it says that, so we asked people if PrEP were available, would you be willing to take it? So this is what PrEP does. Would you be willing to take it? And the vast majority reported that they would be interested. Now that was in 2018. This is all before COVID, kind of in the midst of the overdose, epidemic. We're still going through that right now, but so I think it's we'll have to see what people know, whether or not they're willing to take it. And then I think we still need to assume that there is ongoing risk within the population, given that we know a third of the PWID people living with HIV are not virally suppressed. Okay. So I'm going to move on to medication for opioid use disorder, and the reason why I'm bringing this up because I feel like this falls also within a harm reduction. I'm not talking so much about syringe service programming because I know that was talked about in other sessions. But for medication for opioid use disorder can also be seen as harm reduction because it is getting someone engaged in care and reducing their harm related to substance use. So the three forms of MOUD are of medication for opioid use disorder are methadone, buprenorphine in combination with naloxone, and then extended release naltrexone. And I think I'm sorry, I forget your name. Yona. So I know you mentioned Sublocade, which is like an injectable long-acting buprenorphine. So, and the bottom line is like all these medications for opioid use disorder work. They work for a lot of things. They help decrease morbidity. They help decrease mortality. They reduce, prevent overdoses. They reduce the risk of transmission for infectious diseases. So if someone is injecting, but then they, start on, MOUD, they are obviously, theoretically going to be reducing their injection frequency. So there are a lot of benefits to, reducing harm, of getting on MOUD and reducing people's harm. And so MOUD also improves viral suppression. And again, this is all meeting the ending the epidemic paradigm. So, and there was a systematic review, basically a paper that sort of reviewed a bunch of papers and a bunch of other studies that, found that MOUD is associated with greater HIV medication adherence and also HIV viral suppression. So we know that people getting onto MOUD compared to not getting on MOUD does work in terms of increasing adherence and increasing viral suppression. So, and this is all kind of getting somewhere, but I did want to talk about DC's response to the HIV and opioid epidemic. So I know, you may not consider us being in the middle of an HIV epidemic among the PWID population, given this, really dramatic and really impressive decline in the number of newly diagnosed cases. But there is an opioid epidemic that's ongoing with record numbers of overdoses in DC. And so some of the response, that DC government, DC Department of Behavioral Health, and DC Health have come up with is expanding the access to Narcan or naloxone. I know that was started by Department of Health, DC Health, which has been taken over by Department of Behavioral Health. Department of Behavioral Health has also increased access to treatment assessment locations. So before you used to have to go to one central location, and now they've expanded it. So they've decentralized this treatment assessment, and if you want to get into treatment, you go through this treatment assessment process. And then DC Health has also supported needle exchange for I think about the past past more than a decade at this point. And so there are 4 active syringe service programs: Bread for the City, Family Medical, HIPS, and Us Helping Us. And they all have different, flavors and sizes. And I think it was really, really, I think, great that Department of Health really understood that and has, these different syringe service programs that can kind of like meet people where they are, different types of clientele. And one of the things about these needle exchange programs is that they are also, I think pretty much all of them have expanded services. So they, will offer HIV testing, they will offer hepatitis C testing, and maybe even linkage, definitely linkage to HIV care where if they have it on site, or linkage to other partners. And then they also, I think most of them, if not all, I'm not sure about Bread for the City, but I know it's a primary care facility. So I'm pretty sure that, all of these agencies are now offering medication for opioid use disorder, which is, I think, a huge game changer, and kind of the point that I wanted to get to. So this is just a slide just to indicate that syringe service programs work, because I'm sorry, I didn't actually talk about this other graph that's in this slide. So basically you see the green bars are the number of cases and the decline, but actually what I didn't point out is that blue line is actually the number of syringes that have been exchanged in the city. So this is from the DC Health report, so you can find that there. But, you know, obviously you can see like this reverse correlation. The more needles that are exchanged, the lower the number of newly identified cases. I did want to talk a little bit about a study that I'm doing right now. So one of the things that I think has become clear is that, you know, we need to kind of do all these things in this paradigm of the ending the epidemic. We need to get people engaged in treatment, reduce viral load. If they're negative, get people on PrEP. And then, you know, there's that other piece about getting people engaged in OUD if they have an opiate use disorder, MOUD if they have an opiate use disorder, to help support their engagement in care and prevention. And so this is a study that we're doing where we're trying to bring services to where people are at through the use of a mobile unit. And we're providing integrated care on our mobile unit for people who inject drugs. So we're providing MOUD, HIV care. If people are not HIV positive, we provide PrEP for them on the unit. We'll do Hep C testing and assessment and refer to care as needed. And then also provide sort of general primary care for people. So we try to be a one-stop shop place and provide integrated care. I think the integrated care model is not new to DC. I feel like a lot of agencies in DC, know that this model can work. I think there is a need to really have sustained integrated care, because I know part of the problem is like some of the funding sources, the funding comes from different streams, and so funding may end for one part of the integrated care and not the other. So I think that all needs to kind of be fixed and stabilized. But I think that integrated care models, and it's become clear, especially when I was putting this presentation together, I mean, there's really a need. There's really an intersection between HIV and substance use. And so you can't treat them as two separate things because they all co-occur in the same person. So you need to be able to treat both things at once at the same time. So in conclusion, so we know that drug and alcohol use leads to increased risk for HIV. The PWID case, newly diagnosed case numbers are declining, but we shouldn't sleep on it. There are effective forms of HIV prevention, like treatment as prevention and PrEP, but we saw that, PrEP awareness, PrEP engagement among PWID is low, but that doesn't mean that it should stay low. And medication for opioid use disorder, it can improve care management. I don't think anyone has looked directly whether or not it can improve access to or engagement in HIV PrEP. So that's potentially a question that needs to be answered. And then there's a need for more integrated care models in DC and sustained integrated care to address the intersection of HIV and opioid use in DC. Okay, that's it. Yes. Do you want to take questions? I'm sorry. Do you want to do microphone?
The last slide, the third to last slide, can you put that back up? I missed it.
Is it this one?
That's the one before the fifth, no, it's after that.
Oh, sorry. Oh, sorry. I am like. Do you want me to do it without that word, without the words? Okay. I have to back up. I can. Magically. I'm going to do this. I'm sorry I didn't actually describe that line, but basically that shows the number of needles. And you can see there's this huge uptick and, a little decline, but, and this is what I heard from the other syringe service programs. I was actually surprised to hear this. During COVID, the volume of exchange actually increased. I think, which surprised me because I know there were like limited hours in, service hours, but I don't think it actually surprised them that much because they they saw the need out there, and I think there may be fewer people coming, but like higher volume of needles that were being exchanged because people were coming for other people.
And so if we can actually, if we can save the questions till the end.
Oh, sure.
And right now we'll move to Kevon's presentation. And then, I'm sorry, I forgot your name. Yona. Yeah. And then if we could just, if Yona, if you could wrap this up just from a clinician's perspective, I think that'll be great to close the session. So Kevon, it's all yours.
Thank you. How you guys doing today? All right, awesome. Okay, so I just wanted to recant my story. I'm no stranger to intravenous drug use, and I thought it would be fitting to give a background of my childhood and how that resulted in me actually using drugs. So just bear with me. All right, let's see. Oh, back. Okay, here we go. So a snapshot of mom. By the time I was 7, my mom was the product of a failed relationship with my father and currently in an abusive relationship with my sister's father. According to my mom, my father's family was so upset that my mother had me that they morphed the situation into one that no one wanted to be a part of. The only time I could ever recall my mom as a sweet, tender woman was in early childhood. They were some of my first and oldest fading memories. For the most part, that warm mother I was introduced to was no longer there. She was physically and mentally abusive. Shortly after I turned 9, I no longer saw any real emotion from my mother. No real remorse, no longer willing to understand, no longer willing to try. She was just bitter and angry, never sad, never mad, not melancholy or disappointed, just angry. There are varying views on the ideal way one should discipline a child. In my experience as an African-American male being raised by a single mother, whoopings were just as common as the occasional rainy day. Generally, they would happen for good reason, and as Christians said, the old adage from the good old book says, I messed that up. If you spare the rod, you spare the child. If you spare the rod, you spoil the child. Sorry. I dare not debate proper discipline nor the Holy Bible. However, my mother would beat me out of anger. The face she would make would terrify me. Beating me felt like an outlet for her. This form of discipline established a clear degree of separation and told me she was my mother and I was the lowly child. She would also say hurtful things when she was angry. I won't quote any of them, but it was clear that her anger forced her to say things without affording her the luxury of thinking first. Some of the things she said really hurt, and most of which I wouldn't find closure with until my 30s. I couldn't trust her with my emotions. Around middle school age, the beatings were so bad that I would go to school covered in welts and bruises on occasion. I was so suppressed as a child, I'd given up the idea that my mom would ever really see me or hear me. This shortly morphed into a quiet resentment of mine. In my household coming up, a child was to be seen and not heard. This discipline would manifest in an unfortunate way later in adulthood. One fateful day at school, one of the welts on my leg started bleeding, so I asked to go to the nurse's office for a Band-Aid. She asked why I needed a Band-Aid, and I told her. But then she asked me to show her, and I refused. So she pulled my pant leg up, and she saw my welts and called the school counselor. That very day, I was placed in foster care, and I would be there for 2 years and finish out my middle school in another city and state. I was never good enough for my mom. It was apparent early on my mom was a tough crowd when it came to me. There wasn't much I could do to make her smile ear to ear or to say with unbridled confidence and assurance that I was her son and that she was proud of me. I never dressed well enough, walked right enough, or talked good enough for my mother to be on my team. She would always champion other people's kids. She would rant and rave about how exceptional this person's son was, and usually the rant followed by an in-person side-by-side comparison. This was embarrassing, hurtful, and would prove to add yet another layer to an already complex adult experience. I was pushed further and further away. There would be instances primarily when around friends or family where my mom would say things that to an outsider would seem endearing. They may have very well been genuine and have come from a good place, but I was so closed off and brimming with resentment that the mere thought of it threw me into a slurry of emotions much too dynamic for me to understand, let alone articulate as a little guy. The most revolting thing to me was when she would give me a hug at church. A hug symbolized a relationship completely contrary to the one we had. It didn't make sense to me. It felt fake and inauthentic. Emotional detachment from my mother. Fast forward to high school. This was just after the Pokemon phenomenon had taken the world by storm. At this time, I had lived long enough to establish new relationships and meet new friends. Eventually, you meet your friends' parents, and when this started happening, I had the opportunity to see what healthy parent-child relationships look like. Some of my friends established safe spaces where they could be vulnerable and heard by their parents. What made this season interesting is that my friends' parents loved me. I would cleave to them and their family unit, always excited to have me over, sleepovers, trips to the park, playing outside in the backyard, and dinner after. I saw examples of what a family looked like and how it operated. This would upset my mom. I had better relationships and rapport with the parents of my friends than my own mother. She would say mean things about them to sully my view of them. I knew those things weren't true. I entered adulthood with self-image issues. My experience with my mother and her consistent disapproval of my parents continued to stick with me well into senior year of high school. I would see other guys that looked comfortable in their own skin, the social butterflies that everyone knew and loved. I would always compare myself to these guys. In doing so, it gave me yet another vehicle to identify out and disqualify myself. This is when I developed the habit of beating myself up. This group of kids I couldn't eat with. I'm sorry. I think I messed up here. There was a group of kids that I couldn't eat with at lunch. That in my mind told me I wasn't good enough or cool enough. I wasn't enough, so I carried on through high school as a music major, practicing voice. I was well known throughout the art school, but I was pretty obscure to the majority. Ironically, in the yearbook, they created a category just for me. For the graduating class of 2006, I was voted shyest male, inadvertently coping with depression. At this time, I'm in Ohio for college. Living on campus was fun. I had friends and people that were excited to see me when I come around. I was befriended by some of the best singers, and to sweeten the pot, they thought I could sing too. So I had plenty of reasons to feel valid, seen, and appreciated. I made sense in this circle, I had found. Be that as it may, I recall times where I just felt lonely. With all this love and affection, I just realized I didn't change the slide. I'm sorry, guys. Hold on. There we go. Okay. With all this love and affection and expression around me, I still had moments where I felt like I was the only guy like me on planet Earth. What stood out the most is my 21st birthday. Now we're all in college. No one has money to go through. No one has money to throw a shindig or anything. But some of my friends knew it was my birthday, and they would see me and wish me a happy birthday. I was never able to shake that only guy in the world feeling. I later ended my birthday in my car next to the liquor store, enjoying the milestone of my first legal alcohol purchase and crying because I didn't know why I felt this way. Dealing with anxiety. Anxiety, I believe, is my oldest roommate. Although I wasn't diagnosed until adulthood, it was evident throughout high school and college. When I would step into a room with other people there, an internal dialogue would ensue. I'd screen the room, and based on body language, facial expressions, and mannerisms, I would begin to tell myself, no, he's going to think you're weird, or don't go over there because they're really cool with each other, and who are you, Add this internal dialogue to the fact that my face could never hide what I was thinking or how I was feeling, and you pretty much have me in high school and college. Inability to accept the fact that I was gay. So in my opinion, and to shamelessly quote Lady Gaga, I believe I was born this way. I remember being in preschool. I was in before and after care. There was a kid there who was a boy, but he looked nothing like me. I was dark, he was light. I had brown eyes, he had green eyes. My hair was coarse, his was curly. And I vividly remember him smelling like pickles. But I was absolutely enamored. I always wanted to play with him and be around him. So I guess the writing was on the wall. In adulthood, however, as a Christian and as a young black male coming up, there was a myriad of reasons why being gay was shameful. It was an abomination according to the Bible. No mother really welcomed the news that her son was gay, and for the guys that I knew that were gay, they hated it. Couple that with my already skewed view of the less than guy that I was, I just didn't like me. Unable to love myself. I found fault in everything about me. I wasn't excited about the way I looked. I hated the bone structure of my face. The shape of my head was weird. I also thought I was weighty. The long short of it here is I saw so many other guys that were gorgeous. They had the right skin, the right hair, the perfect physique. They were the guys that I knew I could never be. This translated into an inner disdain that I'm just starting to process through in adulthood. All right. There we go. Looking for love in all the wrong places. So unable to find things about myself that I like and not really sure what it looked like for someone to love me, and not really sure what it looked like for someone to love themselves, I began to seek it out by hooking up with guys. Another guy finding me attractive enough to have sex with gave me validation and affirmation. This exchange is what told me I was worthy of love, something I could never manage to do for myself. It made life as a gay man valid. I was on the gay dating sites, and eventually I hooked up with a guy, very attractive, and it was consensual. This was the encounter that exposed me to HIV. It wasn't until months later, after I'd had the flu for what felt like forever, that I would test positive for HIV. I learned years later that the guy I contracted HIV from was an IV drug user. The good, the bad, and the ugly. The good, the community I found. There was friends that I had when I was using. I was able to build bonds with these people, and we bonded through the trauma of our use, if that makes any sense. Hanging out for days on end, going from place to place, meeting different people, and you get numbers here and you get numbers there. So there was a sense of community there for me that I cleave to. Let's see. Even in my use, I was always known as being the better of the bunch, genuine and trustworthy, always willing to help and consider others before myself. So people usually took to me. They trusted me to be in their place, in their space, and they wouldn't mind having me over. And then you have the bad. Plenty of unsavory characters when you get around the scene of use. You have the casual user, and then you have individuals that's devoid of moral compass entirely. I've had things stolen. I've been assaulted before. People take advantage of you in many different ways. So the bad definitely takes the cake here. As an addict, also, sex was a common transaction for drugs, even if it wasn't warranted. For example, if there's a dealer, right, that he has a place and he's hosting and there's guys that's coming over to use, well, if you're coming over and you're using his drugs, it's expected that you're going to have sex with him. So that was part of the bad there also. And I also had some disparaging experiences with couples. So much so that if I bump into someone and I know this person is partnered, that I kind of stay away. Lots of trauma around that area. Let me see. Okay. Now we've gotten to the ugly. Not only did the drug bring validation through sex, it also made me comfortable in my own skin. It gave me that liquid courage and confidence that I saw in those attractive guys that I admired. This need to feel confident and secure and more accepting of myself took me from casual sex-driven use to necessary use. My depression and anxiety was exacerbated by my use, forcing me to use more to normalize. I would soon lose a second job shortly after moving into my first apartment, and I was eventually evicted from my apartment and lived sofa to sofa for the greater part of 2 years. So I'll just touch on trust issues. I know we don't have too much time. I've had many different examples of breached trust. For example, when I had my apartment, and mind you, my sister was living with me at the time. She was my younger sister. Thinks the world of me. And this was a trying thing for her to go through also, to see her brother go through this. But I would bump into friends in the circle, and me being a nice, caring, and giving person, I had my own place, so I would offer people, a place to stay. After the come up, there's always a big come down. You have to go to bed, you got to go to sleep, you got to eat something, all those things. So I availed my place to a friend of mine, and said friend, he and I had some good times, and he and I had some really bad times. There were instances where I wouldn't be home, but he'd have 2 or 3 or 4 people at my place, and my sister's there like, what the hell's going on? And so she's literally terrified to come out of her room. She locks her door, and then you have me, and I'm out using, so I'm not even thinking about my phone anyway. So it was a bad time. And whereas I thought I could trust my friend, when you're in active use and your judgment's clouded, you're liable to do anything, friend or not. Stigma amongst family. So I do know the majority of my experience in use. Being a crystal meth addict was frowned upon in the gay community. And it's really, really weird because I know it as a gay sex drug. That's how I was introduced to it. But in that same family, there's guys that's either all for it or completely against it. And so that leaves you in this weird area to where you're kind of typecast. And God forbid you tell the wrong person that you actually do meth or you do tea, and you'd never hear from them again. So this led to me using in secret, right? So I would use I would use, and then I would go to the hookup or to whoever I was going to go see, or I would get there and I'd have my paraphernalia on me, and I'd go to the bathroom and I'd minister really quick, and then I'd come back out. So there was lots of that. Of course, that came with additional shame too. That didn't help my case either. And I'll bump down to not knowing when to ask for help. I am the only male child and the oldest of 2 kids to my mom. And even though my childhood was rough and a little tumultuous, I was the guy that kind of held us together. And I think that's really what exacerbated me in adult life. I was the one that refereed the fights between my mom and my sister. I was the one that, had to keep a cool head when everyone else was going crazy. So I was usually the person that was sought out for assistance, that was asked for help, that was, the peacekeeper, the right maker, So when it came down to this particular instance where I'm using, and I used over a 7-year period. It started out as casual, and then it got out of hand. I never knew when to ask for help, and it resulted in me, like I said, losing my place, eventually losing my job, and even while I was still living pillar to post and going from place to place, I still couldn't admit to myself that I had a problem. And this comes down to the life became unmanageable part. I would end up in the hospital. I'd be using and awake for a week at a time. And I didn't know what was going on at the time, but when I get to the hospital, I found out I'm dehydrated. So there's multiple occasions where I had to go to the hospital to take an IV and get my levels correct. And I literally couldn't live. At this point, I was homeless. And I was operating and living off the good graces of dealers that I knew. And of course, with dealers comes the drug, so it was a never ending cycle. But eventually I ended up calling my mom one day after I got out of the hospital. I was at Howard University, and she came and picked me up. And with all the resentment in my heart, I went home with her, and I decided to stop using and to confront the issues that forced me to use, and to get a better understanding of why I used. And that's what's led me to where I am today. I'm currently the Regional Housing Service Chair for Oxford House. I counsel many men and women that are in recovery from alcohol and drug abuse. And it's really rewarding. And I find that, my experiences and the things that I've learned, I could help and teach other people. Give them some ways to cope and ways to get through the situation, and let them know that no matter how bad you think it is, it can only get better. So I've taken up enough time. Thank you so much, guys. I appreciate it.
And so, first of all, thank our wonderful panelists. Unfortunately, we are out of time today. So, Yona, I'm sorry we didn't get to hear from you. However, if you do have any questions, Yona is a physician assistant. PA. So if you have any questions just about clinical experiences, please feel free to ask Yona. And if you have any questions for our panelists, definitely feel free to follow up with them as well. But otherwise, it is now time for the closing plenary session, so everyone can head back to the ballroom.